Welcome back to Cancer Buzz. I'm your host, Summer Johnson. On this mini episode, we continue our review of strategies to address inequities in cancer care. Today, disparities in end-of-life care. End-of-life care focuses on quality of life, comfort, and support for both patients and caregivers during a difficult time. But racial and ethnic minority groups experience systemic barriers to accessing palliative care. Dr. Cardinale Smith is an associate professor of hematology and medical oncology, the chief quality officer for cancer services, and director of the supportive oncology program at Mount Sinai. She also specializes in geriatric and palliative medicine.
I think that there are a couple of challenges. One is that we end up having conversations with patients around their goals of care late in the disease trajectory. And so often this happens once life-prolonging, systemic cancer-directed treatments are no longer appropriate or available to be offered. And that happens for many reasons. I think one, oncologists in general are just poor at being able to prognosticate. It's hard to have objectivity when you have a patient that you've built a relationship with. And we know in this part of patients, and in particularly minority patients, that they tend to overestimate prognosis. So if you have a physician who's overestimating and a patient who's overestimating even more, then you have this idea of what prognosis looks like that is, far from reality. I think then that there are, the potential implications of bias that come into play among clinicians. If the narrative that exists in the world, so to speak, is that minority patients are less likely to want to talk about end-of-life care, are less likely to want to have goals that are aligned with more comfort or supportive care only kinds of treatment plans, then the physicians internalize that and are less likely to have those kinds of conversations with particularly their minority patients. So I think those are some of the challenging upstream physician-specific or patient-specific barriers.
What about the systemic barriers when it comes to end-of-life care for minority patients?
When we then think about the services and sort of the system as a whole and what services are available, well, I think hospice is an absolutely fantastic benefit, and we know it's linked with positive outcomes. Those are in those patients and their caregivers who are able to do that. The support, the hands-on practical support of hospice is low. While they can provide a big picture view support, the actual person in the home to help bathe, change, feed a patient should they need those services are low and really fall to family caregivers. And often disproportionately in minority communities, there are members of the household who need to go to work and who aren't able to take on that kind of a caregiving responsibility. And so when we look at rates of enrollment in hospice, for example, among minority patients who are racial and ethnic minorities, that also plays a role. And then I think that there's, the history of systemic structural racism that goes into play here as well, particularly mistrust that exists among the Black community specifically, and that the health systems still have much to do to really overcome many of those barriers.
So what are some approaches that cancer programs can take with their patients, specifically racial and ethnic minority patients, to have those conversations sooner in care?
I think, one concrete way to do that is really to provide better measurement of the social determinants of health. A lot of what we talked about really is related to what environmental structures exist for our minority patients. And understanding what that looks like, being able to partner with community resources. For example, if there are navigation programs that can help assist and facilitate with these conversations, really being able to partner with faith-based communities in whom we know patients of color really do get a lot of their advice and guidance, not just spiritual, but also practical, is something that can be helpful. I think we talk a lot about implicit bias training, and while I think that is certainly step one, I think that there are a multitude of other things that need to happen, right? I think systems need to understand what their outcomes are of their minority patients compared to their non-minority patients, to be able to identify where those areas of opportunity are that they can put practices in place to really support patients of color. I think it's not simply enough to say, train oncologists in how to have these conversations. You also have to know sort of where in that care trajectory and care pathway your patients of color sort of fall off that cliff, and so that you can provide better support to them.
Everyone wants to do a better job helping their patients make end-of-life decisions. What are some better ways we could approach these conversations with our patients?
When I think about my palliative care background and the training that I had in communication, one of the key tenets is that you sort of use the same communication scaffolding for everyone. And then based on what they tell you, it's where the conversation goes. So for example, I walk into a room and I say to someone, can you share with me what you know has been going on with you and your cancer up until this point? Because then, as opposed to me going in and say, so I see on your scans XYZ thing, if a patient doesn't know that or they've not connected the dots, then you've sort of sent them on the tailspin where they're really just dealing with all of this emotional data. And it can be hard when you're anxious, stressed, sad, upset, to then think about the cognitive part of those conversations and think about a care plan and moving the conversation forward. So I think going into those conversations the same way for every patient, asking, how do you like to hear information? How do you like to have bad news? How do you like to hear good news? And I think it is taking that approach for everyone the same way every time that will obviate many of those assumptions that you may have about the person in front of you solely based on what they look like or what insurance type they may have. This is hard and complicated, right? If it wasn't, I would like to think that we would have solved it by now. But I really do think, there is no sort of one size fits all approach to this. I think it really is coming at this from different avenues and in order to improve outcomes of these patient populations. That's going to be really critical.
Be on the lookout for more conversations on disparities in cancer care. Until then, for the Cancer Buzz team, this is Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.